Hello and welcome to the December edition of the JVS Online Journal Club. My name is Brittany Frazier, and I'm honored to be the Young Surgeon Section host. I'm coming to you from Prisma Health and University of South Carolina in Columbia, South Carolina. Tonight, we have two exciting papers to hear about and discuss. The first of which is early outcomes of off-the-shelf thoracoabdominal multi-branch endoprosthesis during pre versus post-market approval period. And the second paper, association between imaging, surveillance, compliance, and long-term outcomes after endovascular abdominal aortic aneurysm repair at Veterans Affairs hospitals. These papers are being presented by two groups. The second paper being presented by University of Washington group, Dr. Smith and Dr. Darkwa, and the first paper being presented by our Baylor Scott and White colleagues, Dr. Fota and Dr. McHale. Also joining us, it's not advancing. There it goes. Our authors. So welcome student Dr. Hahn, Dr. Zettelman, and Dr. Hahn, and from another USC, University of Southern California, as well as Dr. Newton and Dr. Goodney from Dartmouth. These sessions are being moderated. Our second session will be Dr. Hingarani, and our first session being Dr. Abai. Couple of housekeeping things before we dive in. Please do stay muted. Do submit your questions or comments in the chat. The moderator may call on you to ask your question. This event is being recorded for later on-demand access. And Dr. Humphreys.
And next month in the January version of the JVS Online Journal Club, we've been lucky enough to get in contact with the authors of the CREST-2 trial, and they're going to be joining us. So we will have the Young Surgeon section presenting both of the transfemoral and the carotid endarterectomy studies separately. And then we've had the authors asked the authors to join us so that we can review each of those independently. So we do hope you'll join us in January. It'll be January 7th at 6 p.m. Central Time. For the rest of the faculty that are on, if you haven't signed up, the sign up for 2026 is open. It should have been sent to all of the program directors. If you haven't received it, I'll put a link in, then you can sign up for 2026 through that in the chat.
So much. And I'm going to stop my screen share. And for Dr. Abai, take it away.
So, hi, thank you for having me be here. Our first paper that we're going to go over is early outcomes of off-the-shelf thoracoabdominal multi-branch endoprosthesis during pre-market versus post-market approval periods. This is from USC, and they've done an impressive 59 patients. But I'd like to invite our presenters to present the paper.
All right. Thank you guys for having us. My name is Alex McHale. I'm going to be presenting on behalf of Baylor and have Dr. Fote with me as well, and Dr. Schutz from Baylor. So, let me make sure this works. Here we go. So, in review, TAMBI is the first dedicated off-the-shelf four-vessel branch endograft to receive commercial approval from the US FDA in January of 2024. Branched EVAR using TAMBI had previously only been studied in clinical trials with strict adherence to enrollment criteria and IFU. And so the purpose of this study was really to show the early results using TAMBI, particularly in an off-label fashion, which is commonly done in the real world. I think that was the purpose of the study. So in the methods, this was a retrospective review of patients undergoing TAMBI at a single institution between April of 2020 and January of 2025 at USC. Again, TAMBI was approved by the FDA in January of 2024, so it had been approved for about 1 year when this study was, the patients were done being accrued for this study. So in the pre-market group, there were 13 patients, and 11 of those were on IFU. There were 2 cases in that cohort that were off IFU for compassionate use of the device. And then in the post-market group, there was 46 patients, and of which 76% of them were technically off-label. The primary outcomes were 30-day major adverse events and mortality. And then secondary outcomes, we're looking at 30-day reintervention rate and 30-day target vessel instability. So I kind of had to review what the IFU for TAMBI was, and I wanted to include it here. So it's for thoracoabdominal or pararenal aneurysms only. It's not for dissections, at least according to the IFU. The visceral segment of the aorta has to be at least 2 centimeters. The neck has to be less than 34 millimeters. The aortic, the neck angulation has to be less than 60 degrees, and then your renal artery target for your seal zone should be between 4 and 10 millimeters, and then for the celiac and the SMA should be between 5 and 12. And then, of course, IFU is you need adequate access both from the iliac and femoral and then brachial and axillary. And then specifically, the paper talked about the off-label uses of TAMBI and kind of where TAMBI was used off-label in their study. One being treatment for type 1A endoleaks from a previous infrarenal EVAR, another being type 3 endoleaks from a failed 4-vessel PMEG, and then again, aortic dissections, any aneurysmal changes after dissections is technically off-label. If there's an urgent repair of a pararenal or thoracoaneurysm with an occluded target vessel, that's off IFU. If it's combined with TBE or IBE, and then total transfemoral implantation or contained ruptures, all of that would render it off-label. So in looking at the results, in table 1, I think looking at the demographics between both the pre-market and the post-market groups, some things that stood out to me is the rate of congestive heart failure was 20% in the post-market as opposed to none in the pre-market groups. And then also 9% were already on dialysis as opposed to none in the pre-market groups. Prior strokes, somewhat higher, 26 versus 15%. And then looking at ASA class, the majority of them in the pre-market group were ASA 3 as opposed to there was a significant percent or ASA 4 and even 5 in the post-market group. And then again, just looking at the kind of anatomical data between the two groups, 37% in the post-market group had a previous endovascular graft as opposed to 15% in the pre-market. And then looking at the aneurysm pathology, again, there was 18% were dissections in the post-market as opposed to 8 in the pre. And then again, I think this last bottom left of the screen, the thoracoabdominal aortic aneurysm extent was there was a significantly higher percentage of extent 1 through 3 aneurysms treated with TAMBI in the post-market group, as opposed to, there's 38% versus only 8% in the pre-market group, and that was statistically significant. And then on the right side of the screen, you can see here what were kind of the off-label indications. Again, previous failed endograft, chronic dissection, total transfemoral approach, contained rupture. You can see the numbers there on the right. And then looking at the metrics here. So preoperative lumbar drain was placed in 41% in the post-market group as opposed to only 8% in the pre-market group. Again, some of the patients in the post-market group actually underwent total transfemoral approach. Procedure time, contrast rates were really not any different between the two groups. Moving forward here, so 30-day outcomes. This is looking here. The 30-day major adverse events were different between the two groups. It was 20% versus 8. And really, the majority of that was related to the paraplegia. As you can see here, I have it highlighted in the second box there. 20% in the post-market group as opposed to 8% in the pre-market group. And you can see here they kind of stratified whether it was ambulatory without assistance, with assistance, or just paralyzed non-ambulatory. You can see there it's kind of an even split. Going down, looking at patients who required reintervention at 30 days was no different between the two groups. Target vessel patency at 30 days was 91% and 93% in the two groups. And then the endoleak rate was not statistically significantly different, is 22% and 15%. And all of those were type 2. That's at 30 days endoleaks. Looking at the reinterventions, I think I was looking at this. One thing to point out is that first patient, one of the 30-day reinterventions was actually a profunda to lumbar artery bypass for spinal cord ischemia. I thought that was pretty remarkable. And then you can see there's a significant several patients who had renal artery occlusions who were treated with, if it was early, it was angioplasty and stenting, or with or without thrombectomy if needed. Um, and then there was a few that had 1A endoleaks that required TVAR extension. And then there was one where there was a type 3 endoleak from the celiac artery that required stent embolization. Coming down here, so actually in this table, they actually stratified the patients whether they were on IFU or off IFU. And again, the 30-day major adverse events were statistically significant, or they were different, and it was specifically, actually, excuse me, they weren't statistically significantly different, but they were pretty close, 24% versus 5. And it was mostly related to the paraplegia. Um, and then looking at whether they're on label or off label, actually off label had higher 30-day target vessel patency as opposed to on label. It was 97 versus 82%. Again, not statistically significantly different, but there was a trend there. So kind of looked at the discussion of this. There was a higher 30-day major adverse event in the post-market group. Again, that's probably a result of the more acute pathology that was being treated in the post-market group. Patients with previous endografts or post-dissection patients. And then again, the spinal cord ischemia, I think, is directly correlated to the degree of the spinal of aorta that's being covered, where there was a higher percentage of extent 1 through 3 aneurysms in that group. Authors did comment that, that 20% rate is a little bit higher than what's normally reported in FEVAR series using PMEG, I believe. And then they comment, that they used a standard spinal cord ischemia bundle, including selective drainage, elevated blood pressure parameters, higher transfusion goals, and then different pharmacologic adjuncts. And they did comment that they transitioned during the course of this study from routine drainage to selective drainage. And then again, there was a significant percentage of those patients in the post-market group were undergoing urgent or emergent repair. And then in comparing it to the Cook, one study with the Cook, the Zenith T branch device, when that was used in acute presentations, there was a spinal cord ischemia rate of 27%, so not far off from that. And then also, there was a study published from the UCSF group that showed a 37% spinal cord ischemia, and that was, again, only in 21 patients. Anatomic factors limiting TAMB include angulation, target vessel anatomy, as well as target vessel, anatomy. This study did show expanded application of TAMB outside of patients who are on IFU, specifically in patients who have dissections as well as previous endografts. They did note that renal artery occlusions tended to occur in pararenal aneurysms, despite the average renal artery diameter being 7 millimeter, which was consistent with the TAMB pivotal trial. In conclusion, obviously, FDA approval of TAMB has led to increased use of TAMB outside of the IFU. It wasn't a statistically significant difference in major adverse event mortality or reintervention rate between the two groups. Again, the post-market TAMB cases often included longer segments of aortic coverage, which did correspond with the spinal cord ischemia. With that, thank you guys very much for your attention, and is there any questions?
So before we go on, I'd like to allow your faculty member who's part of this also to make some comments. So would you please take the floor? Thank you.
Thanks, guys, and great job, Alex, presenting the paper. I would like to congratulate the USC team for doing such a robust number of cases. I think in total upwards of 59, which is remarkable. It's probably most significant number of cases done in a single institution in the US. That being said, I think this paper tells us lots of different things. Number one, the selection criteria for patients who were enrolled in the TAMBI IDE trial were quite strict, and these were patients who did need to meet strict IFU criteria. I know at our institution, we submitted, I think, in total 59 patients, of which only 8 were ultimately selected for the clinical trial. That being said, once the device did make it to the market, we, within the vascular community, are sure that more wide-range patients would be ultimately subjected to, or not subjected, but undergo treatment with the TAMBI graft. A couple of things that I thought were very interesting in this paper. Number one, there is a significant risk of branch vessel occlusion with utilization of the TAMBI graft, particularly as mentioned in the paper for pararenal aneurysms and in locations where the aorta is somewhat narrow. Secondly, I think this is probably an accurate demonstration of the spinal cord ischemia risk, especially for patients who are undergoing extent 1 through 3 aneurysm repair. Although it is higher in this paper, it's probably a real world, realistic rate of ischemia that most of us should expect if we're going to treat complex patients like this. So it's important for us to remember this when we're thinking of treatment options for patients. That being said, I also, would like to point out that some of the other studies in the trial, including that from the UCSF group, as well as the Zenith clinical trial, also had a high representation of spinal cord ischemia. But again, those are probably realistic things. And when we go to clinical conferences and we go see papers reporting 1 to 2% spinal ischemia rates, we have to be critical when we see that. I just want the group to remember that. But overall, great job from Dr. Hahn and his team. I think they're doing fantastic work, and I think this paper really gives us a real world idea of how TAMBI is going to react in complex anatomy.
Thank you, Alex and Mazen, for this great presentation and going over this great paper. I was also impressed by the number of patients that were in this paper from one single institution. One of the interesting things was that when I was reading their conclusion, it says that, there's no statistically significant difference between the adverse events between the pre-market and post-market. And I noticed that the numbers were clearly different, although maybe not statistically significant. I want the authors to give us a little bit of a commentary on that point.
Yeah, thank you, Dr. Abai, for that question. I think Dr. Hahn is also on, so he can also supplement kind of what we've kind of found. Yes, we agree that there is no significant difference statistically, but clearly there are differences. You see a jump in the spinal cord ischemia rate almost up to 21% from a single-digit percentage, and you also see major adverse events. And then just numbers-wise, you see the renal artery outcomes. We have I believe 3 right renals that go down in the post-market group, and then 1 left renal that goes down as well. So I think those are valid concerns, and with a greater statistical power in the cohort, I believe that we would have uncovered statistical difference that would bring either concern or more realism to the conclusions that we are making. I would like to just mention, for example, like the right renals have been going down a little more than the left renals, and we are working on additional statistical analysis and also papers on a more granular vessel level analysis to better characterize these outcomes. And since this cohort has been collected until January of this past year, we have a lot more cases that we would also like to add and really update so that we can really exemplify and kind of show research-wise that there are significant differences, or if there might not be. ultimately.
Just to ask a question, since you mentioned the renal artery issues, and we know that this is an issue with the TAMBI device. The numbers aren't too high, but still significant if you're losing kidneys. What do you think is the issue with the renal arteries going down? Is it the size? Um, is it the direction of the branch stents? I've often thought that these devices are very restrictive. Like you can only have branches from the top. How about if you go from the bottom for the renals and from the top for the SMA and celiac? If your branches were different directions, would that matter? And if the authors could comment on that, I would appreciate it.
Yeah, I think I can take that question, Dr. Bai. Thanks for the question. And Kenneth, actually, I'd like to just quickly mention that he's applying for integrated residency right now, so in the middle of the application cycle. So great job answering the questions, and congratulations, Alex and Mazen, for the excellent presentation. I could not have done it better myself. So the renal artery outcomes is, I think, a primary focus of the next phase of really critically evaluating the performance of TAMBI and learning what this device can and cannot do, and learning about the optimal patient selection. So obviously not from this small initial cohort, but we're working on multi-center data set that Dr. Fote also is part of. That so far we have about 240 post-market patients that we're gathering together, and also working with leveraging the pivotal study cohort now having more extended follow-up. I can kind of give you a preview of the trends that we're seeing. Hopefully, it will come out in the future presentations and publications. Is the right renal seems to be more prone to occlusions, and the risk factor seems to be small target vessels and definitely small aortic diameter. The current IFU of the TAMBI device has 20 millimeter as the smallest minimum trans aortic diameter at the renal level. And we think that this is too small, and expanding that to a newer, larger threshold as sort of best practices and even challenging the current IFU is currently sort of being considered based on the data. The directional branch, I think, outcomes to be more precise. The primary patency of renal directional branch constructs ranges anywhere from high 80s to low 90s within 1 to 2 years. In literature, not just TAMBI, but other devices that have been around outside US for longer, like Cook Zenith T branch that Dr. Tudor invented at UCSF, that are widely used in Europe, as well as the new the inner branch construct in outside Europe as well. And so I don't think the renal branch performance for TAMBI system is an outlier or inferior to what's available outside. But I think this is sort of the only dedicated commercially approved manufactured device for 4-vessel integration during repair. And so we're learning a lot about how to use this device more optimally.
Great. Thank you, Dr. Han. Some of the questions from the audience, Brittany Fraser was asking, was the pre-market criteria too selective as compared to the more real-world use? Why or why not? And I'll add another question. Why didn't you select out the urgent cases from the rest of the cases?
Yeah, I can answer that question. I think the restrictive IFU or the inclusion criteria is pretty typical of any pivotal trial. I think the Dr. Fote's experience of sort of 10 to 1 failure to inclusion is pretty typical of any pre-markets the IDE study. And I think that highlights the clinical need beyond that restrictive criteria. So in some ways, Brittany, I agree with you that it was important, I think, for us, and that was sort of the purpose of this study, to report the real world application and the outcomes that we're seeing. And that was also the reason why we included ruptures and symptomatic. We were not aiming to reproduce pivotal trial results. We just wanted to compare and really see what the usage pattern was and what the outcomes were. And so we're starting to see the difference. And if there is a take-home point, if I may say, from our study, I think Dr. Fote summarized it really well, and I want to echo this, that particularly the spinal cord ischemia and some of the other major adverse events that we're seeing is real, and that's sort of the range that I think particularly the centers that are adopting TAMBI for the first time is going to deal with. And I think what's important for these patients is going to be the ability to rescue them from spinal cord ischemia, ability to get them back so that you don't have mortality following major adverse events. I think that's what's going to separate sort of the center that are more mature. And I think part of the training of the TAMBI is not just implantation of the TAMBI, but a bundled postoperative care and rescue protocols.
Thank you. This brings us to the next question, which is by Bill Schultz. This is in regards to the topic that you were touching on, the spinal cord ischemia. How are you selecting patients for prophylactic spinal drainage for TAMBI cases? And is this different than your other devices?
Yeah, so prophylactic spinal drain usage has evolved during the trial, as Kenneth already mentioned. This was because we worked so closely with our neurosurgery group who placed these drains that we created this code spinal stroke protocol where we're able to now activate this code and get the drain in within an hour and transfer the ICU really fast. And so that has enabled much more selective drains. The current subset of patients who are high risk are the ones that have pre-existing chronic occlusions of the key collaterals, like the hypogastrics or the vertebral arteries that cannot be preemptively revascularized, or patients who had previous spinal cord ischemia from the initial either arch or descending thoracic coverage. And in those patients, we tend to still get them prophylactically. And that's not device specific. That's with PMEX, that's with any other device that we would do this.
Another point that Bill touches on is there any role in staging the procedure to decrease the rate of spinal cord ischemia? Does that help at all?
Yeah, I think the data is pretty clear that staging whenever possible is a mitigating factor. But when patients come in with symptomatic or ruptured, you don't have the luxury to stage, and that may be contributing to higher incidence of spinal cord ischemia. Again, that's also not device specific.
Great. Thank you very much. I think that's the end of the questions for this session. The only one other comment that I will make is that I wonder if the real answer to some of these devices is that whether what we need is not just squares or circles to fit into each other, but whether a combination of branches and fenestrations is a good idea rather than having all branches or all fenestrations. I'll leave it at that if anybody wants to comment.
Thank you so very much for that discussion. Very important as we find solutions for the visceral segment of these complex aneurysms. For our next paper, we'll have Dr. Smith and Dr. Darkwa presenting association between imaging surveillance compliance and long-term outcomes after EVAR at Veterans Affairs hospitals. And to moderate, here is Dr. Hingvarani.
I want to thank the great job that you guys have put together for putting together this session. This is an article from the December JVS, and also it's a remarkable article. I think it helps push the field forward. It's again, association looking at EVARs and surveillance. I'll go ahead and let the authors go ahead and, sorry, the introduction take place. This is from the Society for Clinical Vascular Surgery. If we can go and hear the introduction, please.
All right, I just want to thank Dr. Humphreys and the SVS and JVS for inviting us to take part today. My name is Matt Smith. I'm from the University of Washington. I'm here with Kay Darkwa. He's one of our fantastic PGY2s who'll present this paper. So he's going to present the paper as mentioned here by Dr. Newton and colleagues, with Dr. Goodney as a senior author out of the Dartmouth campus. And this topic doesn't need a whole lot of introduction for this audience. I mean, since 2021, EVARs have been greater than 20%, or sorry, greater than 80% of all aortic aneurysm repairs done in this country. We're a little bit higher than other places around the world, but that number is probably maybe pushing 90% in some places. And I think most of our junior trainees would be able to tell us that after an EVAR, it's surveillance, surveillance, surveillance. We get a CT scan in a month, and then most of them will tell you that most of us do ultrasounds in a year, unless something's funny on the ultrasound, then we do a CT scan then, or if we can't see the ultrasound. But the real question is kind of like, is that necessary? And so our guidelines with the SVS, which are getting a little bit older now, but we do this because these are what the guidelines say. This is what we've all been taught and what we've been doing for a while. But one important thing is that if you look down at the evidence that these guidelines are based on, this is all 2B and 2C evidence, which is really one of the worst segments in this entire consensus guidelines. It's really very poor evidence. In fact, if you look at the individual articles that were cited within this evidence, all of them actually argue against this surveillance. If you look at their points just based on the fact that aside from that first postoperative CT scan, most of the other surveillance programs didn't show differences. The European guidelines are a little bit more nuanced and a little bit fresher. Came out last year, and they demonstrate that for patients that don't have a significant endoleak, don't have high-risk features, and don't have a short seal zone, we can probably actually spread that out to imaging every 5 years, with a little bit of nuance for patients in between all of those things. And so this is potentially where we're heading. I think that this paper that Dr. Dark was going to present is a really important addition to the ongoing literature that really asks the question of what happens to patients when they don't get that recommended yearly surveillance after an EVAR, and how can we use this to better tailor our surveillance to potentially make this very expensive procedure a little bit more economical in this country. So with that, I'll let Dr. Dark tell us about the paper.
All right. Good evening, everyone. I'm going to start sharing my screen. All right. Good evening. My name is Kay Darkwa, and I'm a second-year integrated vascular surgery resident at the University of Washington. The paper that I'll be reviewing today is titled Association Between Imaging Surveillance, Compliance, and Long-Term Outcomes After EVAR at VA Hospitals. This is a paper by Newton et al., published in the Journal of Vascular Surgery this year. This study examines how well patients adhere to animal imaging after EVAR and whether that adherence truly affects survival, rupture, or reintervention rates. So for some backgrounds, Current SVS guidelines recommend lifelong annual imaging after EVAR, whether with the CT, duplex, or MRI. But in reality, compliance is poor. By 5 years after EVAR, nearly half of patients miss their surveillance imaging, according to a study by Andraska et al. Published in 2022. The key clinical question that the authors asked is, does complying with guideline recommended annual imaging meaningfully improve long-term outcomes such as mortality, reintervention, or rupture? This is the central clinical question that frames the entire paper. So in terms of the study objective, the authors sought to determine whether compliance with guideline recommended annual imaging is associated with key outcomes, namely mortality, reintervention, and rupture. This was done in a large cohort of U.S. veterans who underwent EVAR. And so this was a multi-center retrospective cohort using VA data from 2000 to 2023. This included nearly 28,000 veterans. This is one of the largest EVAR surveillance data sets ever published. They categorized patients into three categories, so non-compliant, partially compliant, and fully compliant. For the non-compliant group, these were patients that had no imaging in a year, in a pre-designated or pre-specified year. The partially compliant group was patients that had one imaging in the same year, and the fully compliant group was the group that had either one or more imaging study every year. It is important to clarify what they mean by compliance. This is not device-specific or risk-specific compliance. It is simply whether the patient had any imaging in that follow-up year. There's a figure below here that is an example of a patient who was compliant in 3 out of 4 years. And so in year 1, right after the index procedure, they had an imaging done, and then they had one more done in year 1. So they had 2 imaging in year 1. Had an imaging done in year 2, had none in year 3, and then had an imaging done in year 4. So for their methods, they use landmark analysis. Now, this is important because this statistical method is essential to understanding the result. So a landmark analysis is used when the exposure of interest, especially in this case, imaging compliance, can change over time. And so instead of treating compliance as a fixed baseline variable, the authors evaluate outcomes beginning after a designated landmark period where compliance is measured. This can help reduce lead time bias because patients must survive to the end of the landmark window to be included in that window's analysis. Importantly, the authors repeated this analysis across multiple landmark periods. And so they had sequential 2-year windows and then sequential 3-year windows all the way up to 10 years after. The outcomes assessed were all-cause mortality, reintervention, and aneurysm rupture. And for their statistical models, those were adjusted for age, sex, race, VA priority group, and the Charlson Comorbidity Index. So with respect to baseline characteristics, the average age was about 72 years, overwhelmingly male and white. This is typical of the VA population. And the comorbidity burden was moderate, going by that CCI of 3.5. And then over the course of the study period, the mortality was 43%. Reintervention was 14%, and rupture was 0.3%. And this is over that 2000-2023 time period. So here are the headline results of the landmark analysis. So the median survival across group was essentially identical. Non-compliant patients was 6 years, and then 6.3 years for the partially compliant and fully compliant group. Now, when you read the results section, you'll notice that the authors report freedom from reintervention and freedom from rupture as time values. And so here it's 0.7 years, and then so freedom from reintervention is 0.7 years, and freedom from rupture is a year. This seems counterintuitive because we usually express these outcomes as percentages. Now, this is happening because of the landmark analysis. The landmark analysis essentially resets the clock at the beginning of each landmark window. So, for example, at the 2-year mark, and then tracks the outcomes forward from that point. And these numbers represent the median time to the event among the small subset of patients who actually had the event that's measured after that landmark period. And so that 0.7-year value does not mean that the average EVAR patient needs a reintervention within, say, 8 months. It means that among the minority of patients who eventually underwent a reintervention, half of those reinterventions occurred within 0.7 years after that landmark period. For the rupture, the median is about 1 year, simply because ruptures were extremely rare in this cohort, only 65 out of 27, almost 28,000 patients. And so with so few events, it's hard to calculate a meaningful median. The takeaway here is that these time values are artifacts of the method and the rarity of the event, and they do not reflect the typical experience of the EVAR patient. So here is one of the figures in the paper. So this is figure 3A. Each small panel, so this figure is the landmark analysis evaluating mortality. Each small panel represents a separate landmark window. So 0 to 1 years, 1 to 2 years, 2 to 3 years. And as I said earlier, they go all the way to 8 to 9 years. Now I've zoomed into the top panel just for the sake of clarity and visibility. But essentially the rest of the image is the same. The y-axis is percent survival. The x-axis is time after the assessment window. The key observation here is that these three curves essentially overlap in every panel. Whether a patient was fully compliant, partially compliant, or non-compliant, their survival trajectory over the next decade was nearly identical. And this is why the authors report the median survival of roughly 6 to 6.3 years across all groups. The authors ran multiple landmark windows, and in every window, the curves overlapped in the same pattern. Those are the windows that are in the second and third panels there. And so, in other words, more surveillance did not translate into better survival, at least in this cohort. This is the same landmark analysis, but now the outcome is freedom from reintervention. And this is where we need to be especially careful in the interpretation. So at face value, the curves suggest relatively small differences, but the summary statistic of 0.7 years can be a little, at least for me, when I was reading this, can be a little confusing for the reasons that I noted earlier. Most veterans never required a reintervention after EVAR. I think it was about 14% across that entire study period. The curves overlap substantially, and full compliance actually shows a higher cumulative incidence of reintervention. And so essentially, more imaging meant more incidental findings. That meant more procedures regardless of clinical benefit. It's important to note that the study does not distinguish between major and minor reinterventions, which can also limit how we interpret this. Again, this is another of the landmark analysis. This time, the outcome that's looked at here is rupture. And this figure can be summed up into one statement that there were extremely low ruptures. Because the rupture rate was so rare, it was about 0.3%, the analysis is statistically underpowered to detect differences between the groups. However, I think clinically the takeaway is still meaningful. Whether you were non-compliant, partially compliant, or fully compliant, the rupture rate remained very low, nearly zero. So while we can't claim equivalence between these three groups, the practical implication is that after EVAR in this the practical implication is that rupture after EVAR in this population was exceedingly uncommon, regardless of surveillance intensity. So this slide represents the multivariable results. So in the adjusted Cox models, mortality showed no association with surveillance compliance. The hazard ratio was essentially 1. For reintervention, this was higher in the fully compliant group with an adjusted hazard ratio of 1.33. And then rupture again showed no significant association, but that analysis is limited by the extremely low number of rupture events. And so this reinforces that earlier message. More imaging meant more reinterventions without any improved survival. Now, the key interpretive point here is confounding by indication, and it can operate both ways. So on one hand, more imaging may simply reflect greater clinical concern, that the surgeon sees something questionable or that the patient has complex anatomy, and so they're imaged more frequently. That naturally leads to more opportunities to detect issues and then intervene on those issues. But in the VA system, the opposite can also be true. Patients who are sicker or more medically complex sometimes miss appointments, avoid follow-up, or have barriers to care, meaning that they may actually fall into the non-compliant group. And so non-compliant does not necessarily indicate a healthier population. When you put these two opposing effects together, the fact that mortality and rupture still show no association with compliance, despite these biases, strengthens the central conclusion that more imaging leads to more intervention, but not better hard outcomes. And so putting it all together with respect to their key findings, so there was no survival benefit, no rupture benefit. There were higher rates of reintervention. So there was a higher reintervention burden in the group that was fully compliant or that ended up having more imaging. There was extremely low rupture rates overall. And the results were consistent across all landmark periods. And so this obviously raises the important question, do all LEVAR patients really need lifelong annual imaging? So comparing this study with prior study, these findings are not isolated. Diaz 2009, Jones 2019, Andraska 2022. These are all studies that suggest that annual CTA for EVAR patients may not meaningfully change outcomes, particularly in patients that had stable infrarenal EVARs and patients with SAC regression. And so there's a growing theme in the literature that is shifting towards risk stratified surveillance based on SAC behavior, device design, patient anatomy, et cetera. With respect to limitations, so this study has several important limitations, many of which relate to granularity, and the authors point this out themselves in the discussion. So this used administrative VA data. So this is data that lacked anatomic details. So details on neck length, neck length, neck size, angulation, device type, whether it's bifurcated versus FEVAR or BEVAR, or patient symptoms. There were very few rupture events. So again, this was underpowered to analyze the outcomes with regards to rupture. And this was a landmark design that omits, and the authors themselves acknowledge this in the discussion as well. This omits events that happened before the landmark period. There are also time varying confounders. So for example, they didn't track the progression of comorbidities over the time of this study. There's also confounding by indication, which I've talked about earlier. And then beyond the VA system, it is hard to generalize this or extrapolate this beyond the VA system. And I think these limitations should guide how we interpret these results. With respect to the discussion, and the authors mentioned this with granularity. So I think this slide captures that nuance missing from the data set, but is important and essential for modern EVAR practice. There's no anatomic detail. There's no device type of complexity. There's no distinction between major versus minor reinterventions. There's no stratification by EVAR indication. I think these factors almost certainly influence true surveillance needs. Complex EVARs, so fenestrated branch, these carry higher risk of endoleak, of targeted vessel stenosis, and sac enlargement. And so by mixing those in with routine infrarenal repairs, The study may actually dilute any benefit of surveillance in high-risk anatomy. And so while I think this study argues against a one-size-fits-all annual imaging, it does not argue for reduced surveillance in anatomic complex EVAR patients. And so, in conclusion, annual imaging compliance after EVAR is not associated with survival or rupture. Compliance was associated with more reinterventions, likely driven by detection bias. These findings support moving towards selective risk stratified imaging intervals rather than routine annual scans for all patients. I think it's important that, again, we interpret these findings in context, especially given the lack of anatomic detail and absence of complex graphed data. Thank you.
I want to congratulate you and your team for doing such an amazing job for this presentation. Your description was quite exquisite, so congratulations. I also wanted to ask a few questions from the authors. I think when this was presented, a lot of people in the audience were a little bit confused by the landmark uh, target, the endpoints. Dr. Goodney, can you mention again why you decided to use this type of analysis as compared to others, and how you were trying to decrease some of the bias associated with other technologies, other techniques used for looking at endpoints?
I'm not positive if Dr. Goodney or Dr. Newton were able to join tonight relative to call obligations, but I was a co-author. That I think one choice of still using the Cox regression was to use traditional methods in terms of what we're used to, but because we do feel that this is a time-dependent process, that missing a single episode of EVAR surveillance likely doesn't have that big of an impact as long as people are coming back into surveillance versus tonically losing someone from surveillance we felt was a bigger issue. So the impetus from using the landmark analysis actually came from certain breast cancers types of studies that had looked at how their access to care impacted the longer term outcomes from them. And as was mentioned, that part of the analyses for this paper said, well, maybe 2 years isn't a sufficient window to actually see a difference. And pretty much from the covariates that we had and the cohort information that we had, which notably lacked some of that anatomic detail, that we did not see basically as big as we varied some of these intervals, I think even out to 5 years, that there was really a significant difference in terms of the response and outcomes for the patients.
I also wanted to focus in a little bit on the low rates of ruptures that you had. I know that your discussion was focused on that this may represent an underpowered study. Um, I actually am very interested in those 0.3% that ruptured. That's remarkably low. And I'm wondering if that actually is a positive finding in terms of the technology working so well that we're getting so little ruptures. You have a very robust database. We didn't really go into some of the follow-up that you had in terms of extraction of the data from CMS, et cetera, and other databases. Um, can you mention a little bit about the finding of such a low rate of rupture in over 27,000 EVARs and how this represents the progression in the technology? And maybe as the technology changes, our surveillance needs to also change.
Sure. I think that some aspects of that could have an element of confounding by indication that's mixed into it, or clinical care practices, that many times VAs may be well equipped to manage elective EVAR procedures, but probably don't have quite the volume of emergent referrals in many regions of the country that other private institutions might. So from an index rupture or more urgent type of repair, I think we have fewer of those within the cohort from the outset. And then I think that also within the population of physicians, there is some indication that there's higher adherence to IFUs in terms of what devices are placed, which probably secondarily will have some outcomes in terms of better results from that. as well as was mentioned, that the capture that we have within the VA across different imaging studies really allows for more comprehensive review of imaging, even if it was not ordered explicitly for the aneurysm study. And that what we found from certain qualitative analyses is that many primary care doctors and nephrologists and radiologists are able to plug patients back into care with their vascular teams when they're seeing reported abnormal findings, which may not be the case in other types of institutions. So I'm not sure that it's purely on a technical evolution of graphs, but I think that part of the broader impetus for the study is that as we've gone through 3 or so major generations of most endographs for infrarenal repairs, particularly, that many of the technologies have maybe plateaued in terms of some of the differences that we're seeing between them and maintained a relative safety profile.
Our practice has been heavily weighted for surveillance using ultrasound. We very rarely end up getting CAT scans. And I was hoping to find some indications, differentiation between the ultrasound CAT scans, and you mentioned MRIs also in the paper. I couldn't find that in the paper, but I'm interested since you're one of the people who knows the data from the inside. How many were CAT scans? How many were ultrasounds? And how many were MRIs, which we don't really use?
Yeah, so the MRIs were definitely in the minority. We actually, I believe, have a research letter to JAMA Surgery Open or JAMA Surgery that had detailed a little bit about the time-based evolution of where people were starting to utilize ultrasound more in their care. So it's definitely something that has increased in frequency, even though maybe not to the fullest extent of what the guidelines initially would have recommended. And ultrasound is common. We also did see a significant overlap of patients that are receiving both ultrasound and CT, and our suspicion is that those cases may be people with renal insufficiency where anatomic data is being clarified on the CT, but flow aspects or endoleaks clarified on the ultrasound.
Specifically, I wanted to see whether or not there was a difference between the ultrasound group and the CAT scan group. I wanted to go a little bit further because CAT scans in our neighborhood require pre-authorization. The patients with renal insufficiency or dialyses or access problems, scheduling problems, really make it more difficult and less accessible for CAT scans. In the office, it's easy, right? I see them once a year. I get an ultrasound, and patients love it. They don't have to deal with all the other issues. I'm wondering if that might be a middle pathway. And did you notice any difference between those 3 different categories, ultrasound, CAT scan, and MRIs, in terms of adherence or in terms of outcomes?
I don't believe we individually associated them with outcomes because there was often within patient variation in the modality. So adherent to the guidelines, most frequently we're seeing the largest number of CAT scans within the first 2 years, and then the ultrasound prevalence picks up after that. So in terms of kind of making a discrete exposure variable, I don't know that I can give you an answer of that sort. But definitely we do see that the prevalence of ultrasound's role in the surveillance is increasing. And it hasn't seemed to necessarily correlate with the mortality aspect from broad strokes view. Getting back to some of the great reviews that Dr. Darkwa raised about our paper, we are looking forward to trying to use some of the VA's other aspects of data sources, things like aiming to use natural language processing on some of the imaging reports, as well as we do actually already have some clinical demographics as part of the corporate data warehouse aspects of the data beyond what would just be purely CPT or administrative billing codes. But we have the asset of having availability of Medicare billing linked to our patients, as well as community claims that are administrative, but we're seeking to look in ongoing work more towards some of that more detailed anatomic structure, and the VA's surgical capture does potentially allow for some things about graft manufacture as well as urgency of procedures.
And one final question, if I could just squeeze it in. 13% of the patients didn't follow up. Can you comment a little about that? Because I think that's an important aspect. You have a huge data set here. It's an embarrassing problem that 13% of our patients have zero follow-up of imaging being performed. this sounds like it's ripe for an opportunity for improvement or further examination of the data and how to do a better job.
I definitely agree. I think that, within the VA, there's a lot of room for initiating broader quality efforts. And so that is one that we will likely consider taking up. That the number, unfortunately, is probably much larger in the generalized community. So the data that we were seeing for our VA rates of having surveillance were as good or better as what we're seeing in most other data sources. But I think that that we can still ensure that people are having safe care as a priority.
Your discussion says that you mentioned that maybe every 3 years imaging would be uh, appropriate, especially if the patients are asymptomatic or they have good anatomic features, shrinking sac, favorable initial outcomes. Can you expand a little bit upon that? Because the Europeans seem to say longer, 5 years.
Essentially, I think there are potential implementation challenges with longer, but some of that in that sort of end table at the end, other sites had suggested potentially 3 years. We had also looked qualitatively with patients as part of a different aspect of this project, as well as providers and family members and caregivers. And the response was pretty uniform that most people felt uncomfortable with stopping surveillance outright, even if they were in a position where they were unlikely to get any further reinterventions. However, most were in a position where they felt like extending the intervals for surveillance might have some benefit to them in terms of the burden that surveillance carries and the relative benefits that it brings for patients.
Thank you so much. This was an excellent discussion presentation, and I really do appreciate your input from the author's standpoint. And thank you for everyone for putting this together. It was really exciting and interesting to hear this really important paper that I do think is going to end up making a big impact in terms of surveillance post-EVAR.
Thank you all so much, and congratulations to all involved. It's been a lovely evening. As a reminder, our next session will be Wednesday, January 7th, 6 p.m. Central Time. Again, we'll have a review of CREST trial CREST 2, trial data, credit under directomy. You won't want to miss that. I hope everyone has a happy and safe holiday season, and we'll see you in 2026.
Thank you.